This is Professor Capron. Welcome to today's presentation on supraventricular tachycardia. Let's take a look at the learning objectives for this presentation. By the end of this presentation, you will be able to identify the ECG characteristics of supraventricular tachycardia, or SVT, understand the physiology and mechanisms underlying SVT, assess and present the clinical manifestations of SVT in patients, explore medical and nursing management strategies for SVT, and recognize conditions related to SVT and their significance. Here are the key terms for this presentation. Please pause the video and make sure that you know each of these terms. If you're still struggling with any of them after this presentation, please come and find me and we'll discuss it in class. Let's discuss the key ECG characteristics of supraventricular tachycardia, or SVT, in detail. SVT presents with a regular rhythm. This means that the time intervals between successive heartbeats are consistent. Unlike atrial fibrillation, which is characterized by an irregular rhythm, SVT maintains a predictable pattern. This regularity helps to differentiate SVT from other types of tachycardias. In SVT, the heart rate is significantly elevated, typically ranging between 150 and 250 beats per minute. This rapid rate is due to the rapid re-entry circuits or abnormal automaticity within the atria or the AV node. Such high rates can significantly impact cardiac output and patient symptoms, necessitating prompt intervention. One of the distinguishing features of SVT on an ECG is the potential obscuration of P waves by T waves. Because of the rapid heart rate, the P waves, which represent atrial depolarization, may blend into the preceding T waves, which represent ventricular repolarization. This makes the P waves difficult to identify and can complicate the interpretation of the ECG. The hidden P waves are a key indicator of SVT. Our interval in SVT is typically less than 0.2 seconds. The PR interval is the time from the onset of atrial depolarization, the beginning of the P wave, to the start of ventricular depolarization, the beginning of the QRS complex. A PR interval of less than 0.2 seconds suggests that the electrical impulses are being conducted rapidly from the atria to the ventricles, which is characteristic of SVT. In SVT, the QRS complex duration remains within the normal range, which is less than 0.12 seconds. This indicates that despite the rapid atrial rate, the ventricular conduction pathway is normal. The QRS complex represents the depolarization of the ventricles, and a normal duration suggests that the ventricles are depolarizing efficiently without any delay or blockage. Understanding the physiology of supraventricular tachycardia, or SVT, is crucial for recognizing how it affects the heart and for implementing appropriate interventions. SVT is characterized by a significantly increased heart rate, which can range from 150 to 250 beats per minute. This rapid rate is primarily due to abnormal electrical activity originating above the ventricles, specifically in the atria or at the atrioventricular node. The rapid re-entry of electrical impulses within these areas leads to a high ventricular response rate, causing the symptoms associated with SVT. One of the main mechanisms of SVT is the presence of re-entry circuits. In a normal heart, electrical impulses follow a single pathway from the atria to the ventricles. However, in SVT, a re-entry circuit forms when an electrical impulse continues to travel in a loop within the atria or between the atria and the AV node. This looping impulse repeatedly stimulates the heart, leading to a rapid and continuous cycle of depolarization. Re-entry circuits can occur due to structural abnormalities, scar tissue from previous heart surgeries, or congenital conditions. These circuits create a pathway that allows the electrical impulse to re-enter and stimulate the atria or AV node repeatedly. Another mechanism involved in SVT is abnormal automaticity. Normally, the sinoatrial node is the primary pacemaker of the heart, setting the pace for heartbeats. In SVT, other cells in the atria or near the AV node can take on pacemaker activity due to abnormal automaticity. These ectopic pacemakers can generate electrical impulses at a rapid rate, bypassing the normal pacemaker function of the SA node. This abnormal automaticity leads to an increased rate of atrial depolarization, which is then conducted to the ventricles, resulting in a high ventricular rate. The AV node plays a critical role in regulating the conduction of impulses from the atria to the ventricles. In SVT, the AV node may become a part of the re-entry circuit or may rapidly conduct abnormal impulses from the atria to the ventricles, exacerbating the condition. The rapid ventricular rate can compromise cardiac output because the ventricles have less time to fill with between contractions. This can lead to decreased perfusion to vital organs and symptoms of hemodynamic instability, such as dizziness or hypotension. Recognizing the physiological mechanisms of SVT helps in identifying the condition on an ECG and implementing appropriate treatments. Treatments aim to interrupt the re-entry circuit or suppress abnormal automaticity to restore a normal heart rate. Timely intervention is essential to prevent complications associated with prolonged episodes of SVT, such as heart failure or myocardial ischemia. Interventions may include vagal maneuvers, medications like adenosine or beta blockers, and in some cases, electrical cardioversion. Now let's explore how to assess and recognize the presentation of supraventricular tachycardia in patients. One of the most common symptoms of SVT is the sensation of palpitations. Patients often describe feeling their heart racing or pounding, which can be quite distressing. These palpitations occur because the heart is beating at an abnormally fast rate, often between 150 to 250 beats per minute. Along with palpitations, patients may experience chest discomfort or pain. This discomfort can range from mild pressure to more severe pain, resembling angina. It's essential to differentiate this chest discomfort from that caused by myocardial ischemia or other cardiac conditions. Rapid heart rates can lead to decreased cardiac output and reduced perfusion of oxygenated blood to tissues. As a result, patients may experience shortness of breath, especially during physical activity. This symptom occurs because the body's demand for oxygen increases, but the heart's ability to supply oxygenated blood is compromised due to the fast heart rate. It's critical to regularly monitor the patient's blood pressure to assess their hemodynamic status. SVT can lead to hypotension due to the decreased filling time of the ventricles, resulting in reduced cardiac output. Conversely, some patients may present with hypertension as a compensatory mechanism. Continuous monitoring of the heart rate is essential. A heart rate significantly above the normal range, greater than 100 beats per minute, indicates tachycardia. But in SVT, the heart rate typically ranges from 150 to 250 beats per minute. Assess the overall stability of the patient. Look for signs of hemodynamic instability, such as dizziness, lightheadedness, syncope, or hypotension. These symptoms suggest that the rapid heart rate is compromising cardiac output and perfusion to vital organs. Continuous ECG monitoring is vital for patients with suspected or confirmed SVT. This monitoring helps in real-time detection of the arrhythmia, allowing for prompt intervention. Continuous ECG provides a detailed view of the heart's electrical activity and helps to identify the specific type of tachycardia. In addition to continuous monitoring, ECG should be performed to document the arrhythmia and assess its characteristics. Look for the key features of SVT, such as a regular rhythm, heart rate between 150 to 250 beats per minute, P waves that may be hidden in the T waves, PR interval less than 0.2 seconds, and a normal QRS duration of less than 0.12 seconds. ECG is the gold standard for diagnosing SVT. It helps to confirm the presence of the arrhythmia and distinguishes it from other types of tachycardia. Regular ECG monitoring is also essential for tracking the effectiveness of treatments and detecting any changes in the heart rhythm. Now let's discuss the various medical management strategies for supraventricular tachycardia. Vagal maneuvers are first-line interventions used to slow the heart rate in patients with SVT. These techniques stimulate the vagus nerve, which can help regulate heart rate by increasing parasympathetic tone. Common vagal maneuvers include the Valsalva maneuver, carotid sinus massage, and the diving reflex. In the Valsalva maneuver, the patient is instructed to take a deep breath, and bear down as if trying to have a bowel movement. This increases intrathoracic pressure and stimulates the vagus nerve. For carotid sinus massage, gently massaging one side of the neck where the carotid artery is located can stimulate the vagus nerve. However, this should only be performed by a trained healthcare professional due to the risk of dislodging a plaque and causing a stroke. For the diving reflex, this is immersing the face in cold water or applying a cold pack to the face. This stimulates the vagus nerve and slows the heart rate. Adenosine is a rapid-acting medication used to treat SVT by temporarily blocking conduction through the AV node. This interruption can terminate re-entrant circuits and restore normal sinus rhythm. Adenosine is administered as a rapid intravenous push, typically followed by a saline flush. Due to its very short half-life, it acts quickly to reset the heart's electrical activity. Patients may experience transient side effects such as chest discomfort, flushing, or a brief feeling of impending doom. These effects are short-lived and subside quickly. It's important to have resuscitation equipment available in case of adverse reactions. Understand that using adenosine is essentially the human equivalent of turning it off and turning it back on again. So this is not something you want to be doing without the entire team present. Then we have beta blockers, such as metoprolol or propranolol, which are used to manage SVT by reducing the heart rate and lowering the blood pressure. They work by blocking the effects of adrenaline on the heart. Beta blockers decrease the heart's workload and oxygen demand by slowing the heart rate and reducing the force of contraction. They are effective in preventing recurrence of SVT episodes. Beta blockers should be used in caution with patients who have asthma or chronic obstructive pulmonary disease due to the risk of bronchoconstriction. They are contraindicated in patients with bradycardia or heart block without a pacemaker. Calcium channel blockers such as diltiazem or verapamil are used to control the heart rate and manage SVT. They work by inhibiting the influx of calcium ions into cardiac cells. These medications slow the conduction through the AV node and reduce the heart's contractility. They help to control the ventricular response in SVT and can be effective in converting SVT to sinus rhythm. Calcium channel blockers should be used cautiously in patients with heart failure or reduced ejection fraction due to their negative inotropic effects. Monitor for side effects such as hypotension, dizziness, and bradycardia. Cardioversion is a medical procedure used to restore normal heart rhythm in patients with SVT who do not respond to medication. It can be performed using electrical or pharmacological methods. Electrical cardioversion involves delivering a synchronized electrical shock to the heart through paddles or patches placed on the chest. This shock resets the heart's electrical activity and restores normal sinus rhythm. Pharmacological cardioversion involves administering antiarrhythmic medications such as amiodarone to convert SVT to sinus rhythm. Electrical cardioversion is typically performed under sedation to minimize discomfort. Patients should be closely monitored for complications such as arrhythmias, hypotension, and thromboembolism. Now let's discuss the nursing management of supraventricular tachycardia. Regularly assess the patient's hemodynamic stability. This includes checking for any signs of hypotension, chest pain, dizziness, and altered mental status, which may indicate hemodynamic compromise. Assess the patient's overall appearance and ask about symptoms such as palpitations, shortness of breath, and chest discomfort. Continuous ECG monitoring is essential to observe the heart's rhythm, identify the presence of SVT, and detect any changes or complications in real time. Be vigilant for ECG changes that may indicate worsening of SVT or development of other arrhythmias. Teach the patient how to perform vagal maneuvers such as the Valsalva maneuver, which can help to terminate an episode of SVT. These techniques stimulate the vagus nerve and can slow the heart rate. Ensure that the patient understands when and how to perform these maneuvers correctly and safely. Frequently monitor vital signs, including heart rate, blood pressure, respiratory rate, and oxygen saturation. This helps in assessing the patient's response to treatment and detecting any sign of hemodynamic instability. Be aware of the patient's baseline vital signs and note any significant deviations. Frequent checks are particularly important during acute episodes in SVT or when initiating new treatments. Educate patients about common triggers for SVT, stress, caffeine, alcohol, and some medications. Encourage them to avoid or manage these triggers to reduce the frequency of SVT episodes. Discuss lifestyle modifications that can help to prevent episodes of SVT, such as maintaining a healthy diet, regular exercise, and stress management techniques. Provide comprehensive education on the management strategies, including their medication regimen, the importance of adherence, and the potential side effects, and explain the use and purpose of any prescribed medications, such as beta blockers or calcium channel blockers, and ensure the patient understands how to take them correctly. Now let's explore some conditions that are commonly associated with supraventricular tachycardia. Structural heart diseases, such as congenital heart defects, cardiomyopathy, and valvular heart disease, can predispose patients to SVT. These conditions can alter the normal electrical pathways in the heart, creating areas prone to re entry circuits or abnormal automaticity. Patients with structural heart disease may have scarring or abnormal tissue in the heart, which can disrupt the normal conduction pathways and lead to episodes of SVT. It's essential to closely monitor patients who have structural heart disease for any signs of SVT. Early detection and management are crucial to prevent complications and improve patient outcomes. Regular follow up and comprehensive cardiac assessments are necessary to manage these patients effectively. This may include echocardiograms, ECG monitoring, and other diagnostic tests as needed. Stress, whether physical, emotional, or psychological, can act as a trigger for SVT. Stress activates the sympathetic nervous system, leading to an increase in catecholamines, adrenaline, and noradrenaline, which can enhance the automaticity and re entry mechanisms in the heart. Common stressors include anxiety, acute illness, strenuous exercise, and emotional distress. Recognizing and managing stress is an important aspect of SVT management. Assess patients for signs of stress and discuss potential stressors that may be contributing to their SVT episodes. Provide support and resources for stress management techniques, relaxation exercises, counseling, and lifestyle modification. Encourage patients to adopt stress reducing practices such as regular physical activity, mindfulness, and adequate rest. Hyperthyroidism, a condition characterized by an overactive thyroid gland producing excessive thyroid hormones, can increase the risk of SVT. Thyroid hormones have a significant impact on the heart's electrical system, increasing heart rate and enhancing the excitability of cardiac cells. Patients with hyperthyroidism often experience tachycardia, palpitations, and an increased likelihood of SVT due to the heightened sympathetic activity, increased metabolic rate. Screen patients with symptoms of hyperthyroidism, such as weight loss, heat intolerance, tremors, and anxiety, for SVT. Thyroid function tests should be conducted to diagnose and manage hyperthyroidism effectively. Treating the underlying hyperthyroidism can help to reduce the frequency and severity of SVT episodes. This may involve medications such as beta blockers to control symptoms and antithyroid drugs, radioactive iodine, or even surgery to manage thyroid hormone levels. Identifying and understanding the conditions associated with SVT is crucial for developing effective management strategies. Seeing the underlying causes or triggers, we can reduce the incidence of SVT and improve patient outcomes. So, in summary, let's recap some of the points we've covered about supraventricular tachycardia. You learned how to identify it on an ECG. SVT is characterized by a regular rhythm. The heart rate in SVT is notably high, ranging from 150 to 250 beats per minute. Due to the rapid heart rate, P waves may be hidden within the T waves of the previous beat, making them difficult to distinguish on the ECG. But the PR interval in SVT is typically short, indicating fast conduction from the atria to the ventricles, and the QRS complex in SVT is usually narrow, helping to differentiate it from ventricular tachycardia, which has a wide QRS complex. SVT is primarily caused by re-entry circuits, where an electrical impulse continuously circles around the atria or through the AV node, causing rapid heartbeats, and this re-entry mechanism is a common cause of SVT. The clinical significance is that we need to monitor for stability and complications. There is a risk of decreased cardiac output because the heart simply cannot pump effectively at that speed, and this does have the potential to progress to more severe arrhythmias, including atrial fibrillation or ventricular tachycardia. Medical interventions include vagal maneuvers, adenosine, beta blockers, and calcium channel blockers, or cardioversion. And as nurses, we need to assess for stability, educate on vagal maneuvers, and discuss lifestyle modifications. Thank you so much for your attention to this presentation. Make sure that you're getting a break from studying every now and then and go out and go do some nursey things.